correcting the sagittal and coronal planes to physiologic and perhaps age normative ranges. But ideally, you can get that done in a variety of ways. You could do it this way. This is how we've traditionally done it, and sometimes that's the best way. But as technology's advanced, we've realized that there's some considerable morbidity to those traditional ways of doing things, and the advent of minimally invasive surgery and other techniques have attempted to circumvent those morbidities and try to reduce the burden on the patient, and perhaps allow us to do these sorts of surgeries or corrections on patients that are more fragile on that basis. So adopting novel technologies is something to be thinking about carefully. You want to do it in a cavalier manner. Having new tools is wonderful. But if you're trying to remedy situations in a manner that is less than thoughtful, less anticipatory to the devastation that may occur, you could get something that you see here. So we don't want to create mass havoc with these new techniques or new solutions. But as with all new things, there's a learning curve. Technology evolves in a way that makes us more facile and safer. And we have to be prepared to change and adapt when we fall into these risks that are unknown or unanticipated. So what's the incentive with traditional adult spinal surgery? The risks are high, 50 to 75% risk of complication in various papers. And then morbidity must be considered relative to the benefits that we achieve. There's also the greater difficulty of doing open deformity surgery in the elderly. And we've seen that historically, making it more difficult to do these large surgeries after the age of 70 or 80. And of course, there's the extreme involved, not only with the index surgery, but with the complications and revision surgeries that are more commonly seen in the more fragile patients. What have we learned in the degenerative world that we might translate into adult deformity? Todd Allen and Steve Garfin down the road did a nice analysis of the economics of MIS spine surgery. And again, this was in the degenerative realm, but on a 2-level lateral versus a 2-level open PLIF. So MIS versus more of a traditional open 2-level degen surgery, and looking at that sequence over 45 days perioperatively. So not just the charges of implants or the hospital stay, but looking more circumspectively with episode of care cost, at least in the short term, revealed about a 10% cost savings using the MIS techniques. And this had a bit more to do with the hospital stay, the transition home versus skilled nursing facility. And the other thing to keep in mind with all this is the implant costs and the direct charges, even hospital charges, are a bit of a moving target. So there's a cost bend that happens as commoditization of these implants occurs. So this was early on when those implants were actually quite expensive in relative terms. What about muscle injury? Well, as you all probably already knew, one of the primary goals of MI surgery is to prevent the damage of all of the supportive tissues on the way into doing surgery and reconstructing the column. And we know from studies like this out of Dr. Kim and Dr. Lee's lab that the multifidus muscle atrophy and trunk extension muscle strength is different when using PERC technique versus open placement, and there's improved muscle strength and diminished atrophy with MIS technique. Blood loss is also an obvious concern for a variety of reasons. With open surgery and adult spinal deformity, you can see the average blood losses here in a variety of studies. So different countries, perhaps different techniques slightly, but anywhere from WashU and Dr. Dobbs, this is Lanke and Bridwell back in 2007, to some of our other colleagues around the world. The average is in the 2-liter range. So not insubstantial in terms of implications for patients. And MIS surgeries, on the other hand, from a variety of surgeons and MIS techniques, reveal about a 400 to 500 cc blood loss. So quite appreciable if you compare those two in a bit of a systematic review manner. And what does this mean in general? Well, there's cost implications. Transfusions are certainly expensive. There has been postulation, some evidence to support that transfusions can increase infection risk, and other perioperative complications come with them. So something to consider in the larger picture when comparing the two techniques for correcting deformity. Infection risks are clearly higher with open technique. These various papers, Goon and Cohen, looked at open deformity, and you can see here from 96 to 2005, a pretty large cohort with 3.5% deep infection rate, 5.5% infection rate overall. And the ranges differ. UCSF's experience was 9% in 2009, Tarosky 5.2% in 2012. And here's a little bit of a compilation with MIS, and you can see Dakwar, and this is Uribe's experience back in Florida, Dakwar writing it up, and you can see here when you compare with at a 0% infection rate and complications overall, 4% minor with some fixation failure. Phillips, on the other hand, had 107 patients, so a larger series, 12% major complications. And they utilize unilateral fixation or lateral plating, which with today's experience or awareness would probably not be done. I think he'd admit that as well. Anand has one of the larger single center series, and he continues to grow that, had 20% major complications. And you can see in his case, some of the details included misplaced screws, and pseudarthrosis was a major complication in a lot of his series, a lot of his patients at L5S1. But notably at that time, he was using the transsacral screw, which he no longer does, and most people have abandoned. So that comprised a fair bit of the major complications. Mike Wang out of Miami had a smaller series, but nonetheless 17% major complications with PGK pseudarthrosis and loss of fixation comprising those. And many of those were laterals, but no infections in any of those patients. So, 4 papers, no infections in any of them. And that's been borne out in several other subsequent MIS deformity papers. So there's definitely less burden. And I will say that open surgery has learned since those variety of papers I presented, and some of the techniques of washing the wound with various solutions, placement of vancomycin powder, other antibiotic regimens have reduced probably that rate down in the 1% to 2% range, or somewhere in that neighborhood, but it certainly remains higher than the MIS experience. ICU stay and the intensity of postoperative care tends to be higher with open. Anand presented this in 2014 with his 50 patients, and a modest degree of deformity with coronal plane deformities from 30 to 75 degrees, but no post-op ICU requirement. And less need for post-op skilled nursing facility or rehab placement as well. Mike Wing showed this with only 30% of patients requiring skilled nursing facility, which is considerably lower than the open experience. Clinical outcomes obviously need to be tended to and need to be both equivalent and durable. This is a NONS group of 50 patients and with an average COB of 42 degrees and a radiographic correction of 16 degrees, as well as a sagittal vertical axis or sagittal plane improvement down to 27 millimeters from slightly over normal at 51 millimeters. But importantly, the clinical outcomes dropped appreciably from about 6 to 3, and ODI dropped from severely disabled down into the 22 range, which is acceptable. DACWAR had a slightly less onerous deformity burden, but nonetheless had a nice drop in both the pain scores and ODIs. So these were sort of early experiences that I've shown you thus far. This is the ISSG experience, and this is a prospective capture of consecutive patients undergoing MIS surgery compared with what we call hybrid, which is some form of MIS and typically open posterior, but not as much need for osteotomies and some of the more aggressive posterior work in this case because of the anterior column work already done in a less invasive fashion. And then an open group or traditional open deformity treatment from the ISSG group. And so fairly large, 280 patients with a similarity or propensity matching of the sagittal and coronal planes, and ODI, as you can see here, was diminished, was decreased for all groups according to treatment. But notably, the EBL was dramatically different and really commensurate with what I already showed you in the prior data review, 500 cc's versus nearly 2 liters. Fusion levels tended to be lower in MIS as well. So smaller surgeries in a sense, less implant utilization dorsally anyway, to provide the same corrections. Again, these are propensity matched to theoretically similar deformities, and lower overall major complications in the MIS group, 12% versus 33% hybrid and 44% in the open group. Another paper that was put together by the same group, complications in adult spinal deformity, and this was an analysis of those 3 cohorts, 20 patients in each group after propensity matching for COB and SVA, as well as the number of posterior levels fused. So we're trying to eliminate the confounder of having longer posterior constructs with the open groups. And we found lower intraop complication rates with the MIS group, 5.3% versus 25%. And overall complication rates were not statistically significantly different because of the power of only having 20 in each group. But you can see 30% in the MIS, 47 and 60% respectively in hybrid and open. So probably a trend there, but nonetheless, dramatically different EBL. And the length of stay, interestingly, was equivalent to open. But in the open group, in favor of that, there was less OR time. So, you know, that needs to be ultimately considered in any sort of cost effectiveness or health economics equation. But complication rate was obviously concerningly high and typical with what we've seen in the literature. So lots of papers on MIS deformity surgery. They continue to grow in their prevalence. But ultimately, the question is, can we accomplish the same corrections with MIS? The answer obviously is no. There's some things that just simply have to be done with open technique. But as we get better, we understand what we can do and we expand what we can do with a minimally invasive technique, that equation changes. If you look at this paper from Zavatsky and our ISSU group, the 118 patients that we reviewed retrospectively with minimum 2-year follow-up, and looking at interbody fusion versus no interbody fusion, what we found was that lateral surgery, and you can see that circled here, provided for the ability to achieve these corrections with less transfusion risk than with no interbody fusion or TLIF use. And if you look at the post-op Cobb, there was an improvement to a greater degree in that regard. Finally, EBL was considerably less than when using the ALIF or TLIF techniques. When we did a subgroup analysis, the lateral approach provided, was associated with less iliac fixation. There was less EBL and less need for transfusion. And interestingly, as I mentioned in one of the prior studies, less extent of posterior fusion or fixation. So perhaps shorter constructs could be utilized to achieve the same correction and similar outcomes. And the lateral specifically was capable of achieving a greater coronal correction. So having said all that, and drumming up excitement for MIS, are there limitations for it? And the answer is yes. If you look at the ceiling effect paper that was performed, it was essentially to look at what we had already done, so retrospective perspective on patients that had undergone deformity surgery with standalone, circumferential, and then hybrid technique to understand with that sort of biased perspective where patients were being chosen to correct what the severity of deformity was with which we were using these techniques. And you can see here it was standalones. Patients had about a 23-degree ceiling of coronal deformity, of CMIS 34 degrees, and with hybrid 55 degrees. So essentially, we were tending to treat more severe deformities with the at least partially open technique, which stands to reason. So there at least from a surgeon selection bias perspective, there's a bit of a ceiling technique in force there. The other thing to keep in mind is that age-based normative goals were starting to come into play as we learned a lot of this, and you can see our work by Renaud Lafage and the ISSG group, and that was utilized to focus some of our attention from an analysis perspective. And Greg did a nice paper on sagittal plane deformity with MIS surgery and looked at the more severe sagittal plane patients. So with those that had greater than a 9.5 centimeter SVA, so this is in the severe sagittal plane deformity category, only 5 of 11 patients, 5 of 11, so nearly half failed to improve. We weren't doing a very good job in that more severe sagittal plane correction. And again, this is retrospective, so keep that in mind. There, interestingly, and very importantly, was no clinical outcome improvement in those that had severe sagittal malalignments, and that stands to reason. If you're not correcting them and they stay in that poorly corrected sagittal plane deformity scenario, then they're tending not to do well. While moderate sagittal plane deformities, and obviously the milder, did quite well and improved. So again, this was sort of early in the zest to do MIS, and then came the ACR and trying to correct more aggressive, more severe deformities. And so Dr. Ekbarnia with the what used to be called LIFTAR and then ACR demonstrated that we could in fact achieve more substantial correction with ACR or equivalent to PSOs. So we looked at that in comparison with PSOs as you can see here, lumbar lordosis preoperatively was corrected fairly similarly between those two cohorts. And there was no difference out to 3 months and 1 year in those cohorts. And then pelvic tilt, another independent predictor of clinical outcome, was also corrected to perhaps a little more effectively in the ACR group, but no change over time. The conclusions we had from comparing ACR and PSO techniques were that there were similar radiographic corrections feasible between the two with respect to pelvic tilt, lumbar lordosis, and thoracic pelvic angle, but EBL was substantially lower, about 40% less than when using PSO technique. So we could perhaps achieve similar sagittal plane corrections in this case using even more novel MIS technique. Complication rates were similar between the groups, again, with typically open technique in the back, or sort of a hybrid with the patients included in that study. This is another great paper by Sethi and Levesque out of Virginia Mason up in Seattle. And you can see here, they directly compared patients undergoing deformities with PSO and lateral lumbar ACR with a dramatic difference in EBL and improvement in pseudoarthrosis, interestingly. Pseudoarthrosis rates quite markedly. Nice head-to-head comparison demonstrating the benefit. So what does this look like in practice? Here's a patient who's undergone multiple surgeries on the left, had prior open posterior surgery with attempted fusions L4 to 1. At some point underwent a motion preserving Denesis placement in the upper lumbar spine. You could see pitched forward quite a bit with a pelvic tilt of 31 degrees, SVA of 9.6 centimeters. So not in great shape in that regard, but presented initially with L5 radiculopathy. So you can see here, ultimately, he underwent a hyperlordotic ALIF at L5S1 to correct and care for the foraminal compromise there and improve his lumbosacral alignment in deference to being a little more aggressive at correcting the tilt. And then an ACR at the kyphotic L2-3 level, and a lateral below that at L3-4 where he had a pseudoarthrosis, and that allowed for percutaneous posterior reconstruction. And you can see a marked improvement in his sagittal profile, and he did quite well from all this. So MIS technique really highlighted there. And as we advance our ability to do more extravagant corrections, both in the sagittal and coronal plane, Mike Wang and others are leading the way to even do minimally invasive PSOs. And in his early case series here, you could see lumbar lordosis being corrected approximately 25 degrees, pelvic tilt being corrected dramatically in the normative range, and severe sagittal plane deformity of 10 centimeters on average corrected down to 4 centimeters with this minimally invasive maneuver in a fixed plane deformity. There are pitfalls. Baseline sagittal and coronal alignment needs to be well understood from a bony perspective. You have to anticipate coronal plane changes and beware of fractional curves that are, again, dysmorphic in nature, whether it's from erosion of vertebra or coronal asymmetry of the sacral end plate. When you place ALIF cages or lateral interbody cages, they're very powerful in neutralizing these lumbar levels, and you cannot correct them from the posterior side once you've placed them. Customized implants placed within the spaces or anticipation of shifting somebody in the coronal plane really is critically important if you're going to use MIS technique. Here's an example of fractional curve, and you can see the L5 vertebra is quite dysmorphic in nature, as is the sacral promontory. And so when placing cages in these sorts of patients who are compensating above in their lumbar spine for these either congenital or erosively dysmorphic lumbosacral areas, you can create a coronal plane deformity. Case in point, this is a gentleman who is actually a physician in his 70s, and you can see here laterals done above his fractional curve, and you can see in the left, the right image on the left after the laterals how he's coronally off. We staged this in anticipation of potentially needing to adjust at the base, and did that subsequently with an ALIF that was a bit rotated, and then percutaneously fixed him from the back and into a more appropriate or reasonably accommodated coronal plane outcome. And here's a more substantial sagittal plane deformity in an osteoporotic woman. You can see ACR is utilized to correct in the sagittal plane in a manner that adjusted her very severe sagittal plane deformity with a kyphoscoliosis. What about durability of results? Here you see 71 patients with 2 to 5 year clinical outcome noted, and average age of 64. And you can see that out to 36 months or beyond, ODI tends to fade a little bit. VAS remained in pretty good shape. So, there's certainly some question about durability, although we do get challenged with other disease processes that may interfere with functional outcomes. But it needs some scrutiny, as does all deformity surgery, in terms of its ability to maintain patients long into the future, given the expense and challenge as well as morbidity of the revisions that are ultimately required. So how do you ultimately decide to do MIS versus open technique? Well, it has a lot to do with your skill set, obviously, and these evolving capacities that we have. But we did try to create a bit of an algorithm for people to utilize, or at least provide framework for their thought process on what to use. This is affectionately called MIS-DEF, MIS deformity algorithm. And so if you look at this algorithm, you can see there's 4 classes, and the more severe sagittal plane fixed deformities all the way on the right still require some form of open surgery, particularly if you're extending into the upper thoracic spine. But as we had a version 1, we may have future versions as our techniques improve over time. As an example, class 3 expanded with MIS-DEF 2 because of the advent of ACRs and many open PSOs. So you'll see this change over time, but it's a nice thing to keep in your back pocket to give you some guidance on, where you're starting to get on loose footing with your ability to truly correct, which is your ultimate goal, these deformities. There's still much to do in expanding our understanding, improving technology and the capacity of the tools that we have, and the application of MIS in deformity correction. But in the end, we want to move to these technologically advanced maneuvers to the benefit of our patients, and hopefully reduce the burden on them and society in managing these very challenging clinical scenarios. MIS for adult spinal deformity can reduce blood loss, length of stay, seemingly complication rates, and perhaps the number of fusion levels. It does allow for expanding indications, and the ranges of correction seem to be increasing over time. But the cost effectiveness and overall net benefits have yet to be determined. And frankly, there's a bit of a moving target there, but hopefully with further time and study, we'll have some solid footing to declaratively state one way or the other that this is something to be continued. Thank you.
Dr. Eastlack, thanks for the talk.
You bet.
I know you have to run, but I just wondered about a quick question about hybrid. what do you consider, how do you define it, number one? And then what do you think is the current appropriate patient for a hybrid construct?
Well, so hybrid historically we sort of defined as minimally invasive anterior column work and then an open posterior, so a combination of the two. You know, that's a matter of semantics. There are, I think the spirit of MIS is that you're trying to avoid destructive techniques of exposure, you know, so if you see once in a while, we'll do sort of an open midline skin incision and then focally try to expose to do a mini open PSO or a mini open Ponte or a series of Pontes, you know, that still I think is in the spirit of MIS, but some might consider that hybrid. In the end, technically, I think the hybrid has been called open posterior anterior column, less invasive techniques utilized. When to use it, you know, I think you use hybrid still if you feel that you need to do that to get enough correction. So an example would be you've done anterior work minimally invasively, you stage it, or even in the operating room, you're feeling that you have too much to release over an extended period of time to get to your target, to get to your radiographic goal. Then I think you open it, you know, and if you're not quite sure, you can always do that midline skin and go after it with the screws and focal releases. But you have to be pretty nimble, you know, you have to be thinking about what your target is and always be flexible in getting there. I think where people get into trouble is they go into those scenarios with a goal of being MIS or a goal of being open rather than the goal being how are they going to get the patient where they want them radiographically and then adjusting their plan as they need to. Does that answer your question?
Yeah,
Or you're looking
yeah,
at
no,
numbers?
I appreciate it.
Yeah, and your target's going to differ. Obviously, you know, these age normative or values you need to be shooting for a little bit, and so, you know, if you're doing an 85-year-old with MIS technique, maybe you're a little softer on where you target them, and that eases some of the burden. But in the end, use the technique that's going to get you where you need to be from a goal perspective radiographically.
Well, it's a great talk as usual. My question is with MIS is improving over the time and the experience with the open approaches, you know, decreases. Would there be a time that the new generation would not know what the plan 2 would be, you know, as far as getting
Right.
to the point where they can do sort of remedy for some of the things that cannot be done with MIS?
Yeah, it's a good question, Barry. It's almost a question I think we have to revisit every 5 or 10 years because of the learning curve and the improvements that we see. Certainly in the ISSG group, there, you know, both in open and MIS, we're revisiting to some degree if our complication rates and some of the downsides of deformity surgery, the PJK rates are improving as we change what we do. And the answer is sometimes yes, and sometimes and seemingly more often no.
Yeah.
Reasons we have a hard time understanding. But, you know, as I mentioned in the talk, I think our infection rates have dropped. I think what we're doing with preparing patients has improved. By the same token, I think we're starting to operate on more patients. You know, we're not as restrained, and that has to be considered in biasing some of that data.
Exactly.
So it sort of in tandem, I think both subgroups groups, the MIS and the open groups, will have to study their learning curves, adjusting for those confounders. And then as we do that and get a handle on each of those independent groups, then compare again. And I think that's even harder on the MIS side, because the technical aspects of the surgery change so dramatically versus open. You know, in open, as an example, we're seeing a lot less PSOs. You know, those are far less common. Or if we're doing them in more challenging
cases.
And we're doing in historically what were more risky locations. We're doing a lot more L4 and L5 PSOs versus before at L2 or L3, where, you know, they were risky, but not as. So
Yeah, easier.
yeah. So it's an interesting question. I don't have an easy answer, but those are.
I think the other argument is that the young surgeons who are trained with MIS, they probably are better in MIS than, you know, the older guys adopting the MIS. So that could be a positive factor.
Yeah, I hope that's true. You know,
I hope
thing
that's true
I
too.
worry about most is people doing the surgery, as I said, to do it with a technique instead of really being primarily focused on the radiographic goals and adjusting.
Thank you very much.
You bet. I got to run, folks, but thank you. Have a great day.
Thanks so much.